Welcome to Pediatric Case Review. Today we'll be discussing osteosarcoma in children, covering diagnosis, management, and outcomes. This comprehensive lecture is designed for pediatric oncologists and healthcare professionals. We'll explore clinical presentation, examination findings, pathophysiology, investigations, treatment approaches, and complications. Throughout this presentation, we'll use a case-based format with multiple choice questions to test your knowledge and enhance learning. Let's begin our exploration of this important pediatric malignancy. Welcome to Pediatric Case Review. Let's begin with our first case. A 14-year-old boy presents with progressive knee pain for 3 months, worse at night. What is the most common presenting symptom of osteosarcoma? Is it A. Pathological fracture, B. Localized pain, C. Systemic symptoms, or D. Joint effusion? The correct answer is B. Localized pain. Approximately 80 to 90% of patients with osteosarcoma present with localized pain, typically progressive and often worse at night. The average duration of symptoms before diagnosis is several weeks to months, highlighting the importance of investigating persistent bone pain in children and adolescents. Here's our next case from Pediatric Case Review. A 15-year-old male presents with distal femur pain. Which demographic factor is most associated with increased risk of osteosarcoma? A. Age 10 to 20 years. B. Female sex, C. Short stature, or D. Family history? The correct answer is A. Age 10 to 20 years. Osteosarcoma has a bimodal age distribution with the first and larger peak during adolescence, coinciding with the pubertal growth spurt. There is a slight male predominance with a male to female ratio of 1.4 to 1. This association with periods of rapid bone growth suggests a relationship between bone development and tumor formation. From Pediatric Case Review, our next case involves a 12-year-old who presents with a thigh mass and pain for 6 weeks. On examination, which localized finding is most commonly associated with osteosarcoma? Is it A. Soft tissue mass, B. Joint stiffness, C. Local warmth, or D. Skin ulceration? The correct answer is A. Soft tissue mass. A palpable soft tissue mass is present in 30 to 40% of patients with osteosarcoma. The mass typically feels firm and is fixed to the underlying bone. It may be tender to palpation and is caused by tumor extension through the cortex into surrounding soft tissues. Local warmth and erythema can occur, but are less common and may lead to misdiagnosis as infection. Our next pediatric case review question concerns a 13-year-old with knee pain and a 5-kilogram weight loss. Which systemic symptom is most concerning for advanced osteosarcoma? A. Low-grade fever, B. Weight loss, C. Fatigue, or D. All of the above? The correct answer is D. All of the above. Systemic symptoms including fever, weight loss, and fatigue may indicate advanced or metastatic disease. Approximately 15 to 20% of patients have detectable metastases at the time of diagnosis. The presence of any systemic symptoms warrants a thorough staging workup, including chest imaging, as the lungs are the most common site of metastasis. From Pediatric Case Review, here we have a 16-year-old athlete with progressive proximal tibia pain. On examination, which finding is most suggestive of osteosarcoma? A. Restricted joint range of motion, B. Local tenderness, C. Palpable mass with bony firmness, or D. Effusion? The correct answer is C. Palpable mass with bony firmness. A palpable mass with bony firmness is highly suggestive of osteosarcoma when present, as it indicates tumor growth through the cortex into surrounding soft tissues. While local tenderness and restricted range of motion may be present, they are less specific findings. Joint effusion is uncommon unless the tumor extends into the joint space, which is relatively rare. Our next pediatric case review question features a 15-year-old with knee pain worsening over 3 months. What examination finding best differentiates osteosarcoma from Osgood-Schlatter disease? A. Night pain, B. Activity-related pain, C. Point tenderness at tibial tuberosity, or D. Soft tissue mass? The correct answer is D. Soft tissue mass. The presence of a soft tissue mass is highly suggestive of osteosarcoma and not typically seen in Osgood-Schlatter disease. While both conditions can present with pain around the knee, Osgood-Schlatter pain is typically activity-related and localized to the tibial tuberosity. Osteosarcoma pain is often present at rest or at night and can worsen over time regardless of activity level. From Pediatric Case Review, our case involves a 14-year-old with distal femur osteosarcoma. Which regional examination finding requires urgent attention? A. Limited hip range of motion, B. Popliteal lymphadenopathy, C. Weak dorsalis pedis pulse, or D. ipsilateral PS planus? The correct answer is C, weak dorsalis pedis pulse. Vascular compromise indicated by diminished pulses requires immediate attention and vascular consultation. Osteosarcomas can occasionally compress or invade vascular structures, particularly when located near major vessels. While lymphatic spread is uncommon in osteosarcoma, making lymphadenopathy an unusual finding, diminished pulses represent a potentially limb-threatening complication that warrants urgent assessment. For our next pediatric case review question, a bone biopsy from a 12-year-old shows malignant cells producing osteoid. What is the cell of origin in osteosarcoma? A. Osteoclast. B. Mesenchymal stem cell. C. Chondrocyte. Or D. Mature osteoblast? The correct answer is B. Mesenchymal stem cell. Osteosarcoma arises from primitive bone-forming mesenchymal stem cells. The hallmark of osteosarcoma is the production of malignant osteoid directly by tumor cells. Based on the predominant matrix produced, osteosarcomas are classified into osteoblastic, chondroblastic, and fibroblastic subtypes, though all produce some amount of osteoid, which is necessary for diagnosis. Our pediatric case review question concerns a patient with history of retinoblastoma who develops osteosarcoma at age 10. Which genetic alteration is most associated with this scenario? A. P53 mutation. B. RB1 gene mutation. C. EWSR1FLI1 fusion. Or D. CMYC amplification? The correct answer is B. RB1 gene mutation. Patients with hereditary retinoblastoma have a 500-fold increased risk of developing osteosarcoma compared to the general population. This is due to germline mutations in the RB1 tumor suppressor gene. Other genetic conditions associated with increased osteosarcoma risk include Lee-Fermini syndrome, caused by P53 mutations, and Rothman-Townsend syndrome. However, most cases of osteosarcoma are sporadic rather than hereditary. From pediatric case review, we have a 13-year-old with knee pain. Which radiographic finding is most characteristic of osteosarcoma? A. Codman's triangle. B. Ground glass appearance. C. Soap bubble lesion. Or D. Onion skin periosteal reaction? The correct answer is A. Codman's triangle. This radiographic finding represents periosteal elevation at the tumor margins, creating a triangular appearance. It occurs when aggressive tumor growth lifts the periosteum away from the cortex. Other radiographic features of osteosarcoma include sunburst pattern of periosteal reaction and mixed lytic and blastic lesions. Ground glass appearance is typical of fibrous dysplasia, while soap bubble lesions are more characteristic of giant cell tumors. For our next pediatric case review question, we have a 15-year-old with suspected osteosarcoma of the distal femur. Which imaging study best defines local tumor extent? A. Plain radiograph. B. CT scan. C. MRI. Or D. Bone scan? The correct answer is C. MRI. Magnetic resonance imaging is the gold standard for local staging of osteosarcoma. It provides excellent delineation of intramedullary tumor extent, soft tissue involvement, and relationship to neurovascular structures. This information is essential for surgical planning, especially when considering limb salvage procedures. While plain radiographs are typically the initial imaging study and CT scans better visualize cortical destruction, MRI offers superior soft tissue contrast. Our pediatric case review question involves a newly diagnosed osteosarcoma patient requiring staging. Which study is most important for detecting pulmonary metastases? A. Chest X-ray. B. Chest CT. C. PET scan. Or D. Bone scan? The correct answer is B. Chest CT. Approximately 90% of osteosarcoma metastases occur in the lungs, making thorough pulmonary evaluation essential. Chest computed tomography can detect nodules as small as 3 to 5 millimeters and is significantly more sensitive than plain radiographs, which may miss up to 50% of pulmonary metastases. Bone scans are used to detect skip lesions and bone metastases, while PET scans can help assess treatment response, but are not the primary modality for detecting pulmonary metastases. From pediatric case review, we present a 14-year-old with osteosarcoma undergoing laboratory workup. Which laboratory finding is most commonly elevated? A. Alkaline phosphatase. B. Lactate dehydrogenase. C. Calcium. Or D. White blood cell count? The correct answer is A. Alkaline phosphatase. Serum alkaline phosphatase is elevated in approximately 40 to 50% of patients with osteosarcoma, reflecting increased osteoblastic activity. The level often correlates with tumor burden and can serve as a prognostic marker. Lactate dehydrogenase may also be elevated, especially in patients with metastatic disease, and carries prognostic significance. However, alkaline phosphatase elevation is more common and more specific to bone involvement. Our pediatric case review question features a 12-year-old diagnosed with localized high-grade osteosarcoma of the distal femur. What is the standard first step in management? A. Surgical resection. B. Neoadjuvant chemotherapy. C. Radiation therapy. Or D. Immunotherapy? The correct answer is B. Neoadjuvant chemotherapy. The standard treatment approach for high-grade osteosarcoma consists of neoadjuvant chemotherapy, followed by surgical resection, and then adjuvant chemotherapy. Neoadjuvant chemotherapy shrinks the primary tumor, facilitates surgical planning, and treats micrometastatic disease. It also provides important prognostic information based on the degree of tumor necrosis observed in the resected specimen. Osteosarcoma is relatively radioresistant, making radiation therapy less effective as primary treatment. For our next pediatric case review question, a patient with osteosarcoma is starting chemotherapy. Which agents are most commonly used in standard regimens? A. Doxorubicin and cisplatin. B. Vincristine and dactinomycin. C. Cyclophosphamide and etoposide. Or D. Temozolomide and lomustine? The correct answer is A. Doxorubicin and cisplatin. The standard chemotherapy protocol for osteosarcoma is the MAP regimen, consisting of high-dose methotrexate, doxorubicin, and cisplatin. High-dose methotrexate requires leucovorin rescue to prevent severe toxicity. This combination has improved 5-year survival rates to 60 to 70% for patients with localized disease, compared to less than 20% in the pre-chemotherapy era. Options B, C, and D represent regimens more commonly used for other pediatric malignancies. From Pediatric Case Review, we have a 14-year-old with distal femur osteosarcoma. Which surgical approach is considered standard of care? A. Limb salvage with wide resection. B. Amputation. C. Marginal excision. Or D. Curettage and bone grafting? The correct answer is A. Limb salvage with wide resection. Currently, 80 to 90% of patients with osteosarcoma are candidates for limb salvage procedures, which offer equivalent survival outcomes to amputation with improved functional results. The procedure involves wide resection with negative margins, followed by reconstruction using an endoprosthesis, allograft, or autograft. Rotationplasty may be considered for distal femur or proximal tibia tumors in younger patients. Amputation is reserved for cases where limb salvage would compromise oncologic outcomes. Our next pediatric case review question features a patient with 95% tumor necrosis in the resected specimen after neoadjuvant chemotherapy. What does this indicate? A. Poor prognosis. B. Good prognosis. C. Need for radiation. Or D. Chemotherapy resistance? The correct answer is B. Good prognosis. Histologic response to neoadjuvant chemotherapy is one of the strongest predictors of outcome in osteosarcoma. Greater than or equal to 90% tumor necrosis in the resected specimen is considered a good histologic response and is associated with a 5-year survival rate of approximately 80%. Patients with poor response, less than 90% necrosis, have a significantly lower survival rate of around 50 to 60%. This information helps guide adjuvant therapy decisions. For our pediatric case review question, a 13-year-old on osteosarcoma treatment develops fever and neutropenia. Which agent is most likely responsible? A. Doxorubicin. B. Cisplatin. C. High-dose methotrexate. Or D. All can cause neutropenia? The correct answer is D. All can cause neutropenia. While doxorubicin typically causes the most profound myelosuppression, all standard osteosarcoma chemotherapy agents can cause neutropenia. Each agent also has unique toxicity profiles. Doxorubicin causes cumulative dose-dependent cardiotoxicity. Cisplatin causes nephrotoxicity, ototoxicity, and peripheral neuropathy, and high-dose methotrexate can cause mucositis, nephrotoxicity, and neurotoxicity. Managing these toxicities requires close monitoring and supportive care. From Pediatric Case Review, we have a 25-year-old survivor of childhood osteosarcoma presenting for follow-up. What is the most important long-term complication to monitor? A. Secondary malignancies. B. Cardiovascular disease. C. Fertility issues. Or D. All of the above? The correct answer is D. All of the above. Osteosarcoma survivors face multiple potential late effects that require lifelong monitoring. Secondary malignancies occur in 3 to 10% of survivors at 20 years, with a particular risk for therapy-related leukemia and solid tumors. Cardiovascular complications include anthracycline-induced cardiomyopathy from doxorubicin, Fertility issues may arise due to gonadal toxicity from chemotherapy. Additional concerns include renal dysfunction, hearing loss, and limb function/mobility issues. Our pediatric case review question concerns a 16-year-old who completed osteosarcoma treatment 2 years ago. Where is recurrence most likely to occur? A. Lungs. B. Bone. C. Brain. Or D. Liver? The correct answer is A. Lungs. Approximately 80 to 90% of osteosarcoma recurrences involve the lungs. Most recurrences occur within the first 2 to 3 years after treatment completion, although late recurrences can occur. Surveillance typically includes chest imaging every 3 to 4 months during the first 2 years, with decreasing frequency thereafter. Importantly, surgical resection of isolated lung metastases can significantly improve survival, with 5-year post-relapse survival rates of 20 to 40%. Thank you for joining us for this comprehensive review of osteosarcoma in children from Pediatric Case Review. Remember the key points. Osteosarcoma typically presents with localized bone pain in adolescence, requires prompt imaging and biopsy, and is treated with a multimodal approach including chemotherapy and surgery. Early diagnosis and multidisciplinary care are essential for optimal outcomes. Please follow our channel for more informative presentations on pediatric conditions and leave any questions in the comment section below. We look forward to seeing you in our next video.